Hello, today we are going to talk about the use of CT angiography and perfusion in the evaluation and treatment of acute ischemic stroke patients, addressing both standards and potential pitfalls. My name is Edward Sloan. I work with fern.org. I'm Professor Emeritus at the Department of Emergency Medicine at the University of Illinois at Chicago in Chicago, Illinois. I also am Medical Director for New Rose Healthcare Management, helping the emergency department at Roseland Community Hospital in Chicago, a safety net hospital. And I serve as Medical Director for the Physician Assistant Studies Program at Dominican University in River Forest, Illinois. This information is being presented at the Clinical Decision Making in Emergency Medicine meeting, June of this year. I want to give my thanks to Joan Esbrey-Cullen, Andy Godwin, Andy Jagoda, Ginia Ports, and Scott Silvers, with whom I've worked at this good meeting for several years. I have no financial conflicts. I serve as the Fern President and Board Chair. So what are the AHA and ASA recommendations? I've pointed out from the recommendations themselves where the specific guidelines are mentioned. So in these following slides where the arrows exist, I will just quickly move through the questions and show you where they are demonstrated in the AHA ASA Neuroimaging Guidelines here. You can see that many questions have good or type 1 recommendations and others have 2 recommendations which are supported less strongly by the literature. But let's go to our conclusions so that you understand best what these recommendations tell us. What about the use of non-contrast CT, IV, alteplase, or other thrombolytic therapies, perfusion studies, and in those with unknown ictus time? What do the recommendations say? The recommendations state that non-contrast CT and MR both exclude intracerebral hemorrhage prior to thrombolysis, so you don't have to do MR studying. The recommendations state give IV alteplase or other thrombolytic therapies prior to MRI or the exclusion of microbleeds on MR. Don't delay IV alteplase to obtain perfusion studies if you don't have those in your center. And CTA and CTP or MRA DWR are useful in certain patients. Which are those? Those especially with Wakeup stroke, unknown ictus time, or when EVT is an option beyond the IV thrombolytic therapy 4.5 hour window. So, if there's a Wakeup stroke or unknown ictus time, you can use MR to find DWI or FLAIR noted patients for IV alteplase within 4.5 hours, or stroke identification of a large ischemic penumbra and a small core infarct beyond those 4.5 hours. What about these other areas? LVO, ETV criteria, vessel imaging, and perfusion studies. The guidelines say if the ETV criteria are met, then you can use CTA or MRA to image the CNS vessels. Or if a LVO is suspected, you can do the same. The guidelines state if there's no renal history, there's no need for a prior creatinine. If an ETV therapy is in play, you should image your extracranial carotids and vertebrals, and you should image the collaterals when considering mechanical endovascular therapies, including thrombus removal. And when you have an anterior LVO between 6 and 24 hours, you can use CTP or DW-MRI to verify the eligibility for EVT based on prior EVT clinical trial results. What about early stroke, LVO, anatomical lesion identification, or EVT itself? So what do the guidelines say about AIS neuroimaging in these situations where you're trying to identify the anatomical lesion? The guidelines say in stroke patients less than 6 hours where the aspect score is 6 or greater with a suspected LVO, you should do vessel imaging with CTA or MRA to guide your use of endovascular therapies and referral to a comprehensive stroke center, as opposed to waiting and doing additional perfusion studies to add to your decision making. In other words, less than 6 hours in patients who may optimally be treated with EVT in order to rapidly allow for evaluation for EVT and transfer. Do the anatomical lesion identification and don't worry as much about the use or need for perfusion testing in order to determine whether EVT should be provided. Thank you for your time in learning more about optimizing the care of patients who present to the emergency department with acute ischemic stroke. You can scan this QR code to find out more about our social media links, and you can send me a question to fern.org@gmail.com or edsloanmd@gmail.com. Once again, thank you for your participation in this Fern educational effort. Have a good day.